Suppose you want to show your professional colleagues or an enlightened payer partner how your direct primary care practice is performing. If you were Dr. Lin Ho, you would go to your website and produce information based on thousands of patients' responses. Each score in yellow represents the percent of patients fulfilling several quality criteria. Comparative data for national respondents in the same age group are also included. Compared to a national sample and an absolute 100% of all patients who might respond positively, her healthcare services are exemplary. To counter the argument by some that her exemplary care might be a consequence of a patient selection bias, she can demonstrate that the pattern of exemplary care quality is applicable to patients stratified by their risk for future costly care. The decreased use of expensive care is noteworthy. Most striking is the difference in possibly unnecessary and avoidable use. With this information, Dr. Ho is able to identify areas of concern also. For patients most at risk for costly care, the percentage who report being very health confident is low, for example. We will return to her activities to increase health confidence in a moment. Regardless of this deficiency, which is still better than the national comparators, the data shows that Dr. Lin Ho's practice produces high quality, with much less use of costly hospital or emergency care. Sounds like an ideal medical practice. In fact, Lin Ho was, and still is, a member of a primary care practice consortium called Ideal Medical Practices, or IMPS. At the beginning of this millennium, IMPS tried to mitigate the stress on primary care by creating efficiencies to dramatically reduce overhead, for example, no waiting room and little, if any, staff. But IMPS knew that merely having low overhead and more time with a patient might not address patient needs and attain best services if the patient and clinician were not on the same page. Therefore, most IMPS, like Dr. Lin Ho, disseminated a standardized assessment and networking technology, or SAINT, that we define in a moment. In comparison, direct primary care practices adopted some IMP low overhead approaches, but focused on the wasteful fee-for-service and insurer areas. DPCs believe in following the money to get rid of waste. References 1 and 2 describe IMPs and DPCs. DPCs radically eliminate fee-for-service and insurer stuff, such as form completion and prior authorizations. DPC practices, almost by definition, do not have to adhere to the acknowledged toxic measurement mess that only vendors and out-of-touch regulators can love. A recent National Academy of Sciences, Engineering and Medicine report provides some justification, saying, in essence, that current quality measures are killers for primary care and a recipe for burnout. However, both NASEM and DPCs may be throwing out the patient with the bathwater. The recent Society of Actuaries report highlights this problem for DPCs. They conclude, further analysis into the effect of the DPC model in primary care on the quality of care, patient health status, and patient satisfaction is definitely needed. The point we will emphasize today is that DPCs are in the enviable position of being able to place a saint at the center of their services. A pun, I realize, but easy to remember. A saint at the center of services. That is the focus of this presentation. More than 3 decades ago, community-based primary care clinicians began to systematically rectify the significant mismatch they had observed between what matters to patients and what clinicians knew. Gradually, they developed a simple and internationally adopted approach that placed them and their patients on the same page. This approach is built on standard, single-item patient assessments and technology that networks the results into actionable information for both patients and the clinicians who serve them. A SAINT, as this combination is called, enables the bark and meow of clinicians and patients to productively communicate and, as the jargon tells us, co-produce better care and outcomes. A SAINT's attributes are that it is easy to use, provides a service that is simple and cheap. It guides action, reduces clinician guesswork about what matters, guides resources, contributes to healthcare reliability and resource planning, facilitates a learning health system for quality assurance, accountability, and improvement, and documents in large controlled trial that it improves quality of service and patient outcomes. Because if it doesn't work in a controlled trial, then maybe you shouldn't use it. Several decades of clinician insights and suggestions, hundreds of thousands of patient uses, and several prospective studies documented that patient-reported health confidence is essential for desirable consequences of health services and patient self-management. To be health confident, people state that they are very confident that they can manage and control most of their health problems and concerns. For example, if 100 employees with diabetes reported they were very health confident that they could manage and control their diabetes and related problems, would they cost more or less than 100 employees who report that they are not very health confident? As you would expect, it is quite easy using multivariate analyses to demonstrate that patient outcomes shown in the lower bubble are strongly influenced by health confidence. As you would expect, the diabetics who are health confident are going to do better, on average, than patients who are not health confident. Health confidence is also strongly associated with the quality of health care, and most important components of practice quality tend to be the quality of information and communication patients receive and their access to this information. None of this should be surprising, but it is surprising we have wasted so much trying to measure all related stuff without, again, to quote the jargon, going where the money is. The bottom line is that differences in costs and outcomes between patients who are very health confident and those who are less than very health confident, these differences are striking. Here are associated medical costs in 2015 dollars and time lost from work for employment-aged adults. Clearly, being a member of the orange bar, which means you are less than health confident, is not a very desirable state for anyone to be in. And when you adjust these results for disease burden, age, gender, etc., the magnitude of these differences does not go away. So being very health confident is a big part of the story of good health, but health confidence does not exist in a vacuum. Several additional measures matter a lot in augmenting or detracting from health confidence, and these additional measures that matter are also worthy of attention. These items are During the past 4 weeks, how much have you been bothered by emotional problems, such as feeling anxious, depressed, irritable, or sad? During the past 4 weeks, how much bodily pain have you generally had? How many prescription medicines are you taking more than 3 days a week? Do you think any of your pills are making you sick? And how confident are you that you can control and manage most of your health problems? The responses in yellow are of concern, and each item with a yellow response is summed to produce a What Matters Index, or WMI, with a range from 0 to 5. In addition to each item being a guide for fundamental issues that matter to patients, the sum of 0 to 5 is a useful way to segment or stratify patients for the risk of costly care. This diagram illustrates the predictive power of the WMI in private practices for chronic conditions, shown on the far left, Medicaid patients without chronic condition, shown in the middle, and Medicaid patients with chronic conditions, shown on the far right. Gray versus blue color of the columns is always a big jump, so we customarily suggest that patients with a WMI of 2 or higher receive special attention because they are particularly high risk. And by the way, the predictive power of the WMI has been shown to be as good as risk models generated from EMR and administrative data. It is very helpful to have a score in real time, understand the cause for its elevation, and know that the patient has already had a sort of heads up about it before seeing you. Compare this to the patient list sent to a practice of those at risk based on a black box algorithm, and who knows what formula based on months or years old administrative data. To tell us how much better it feels in a DPC to work with a saint and the WMI, we will now hear from Dr. Lin Ho.
John's presentation deals with data, lots of crunchable data, and the conclusions that can be drawn from that data. I'm going to switch viewpoints and talk about why I, as a clinician, continue to use this SAINT What Matters Index process during routine wellness visits to help me with the patient in front of me and to improve my practice. To recap, when my patient takes the free online survey prior to or during a visit, I will receive 5 vital pieces of information about the patient in front of me that are foundational to health: medication issues, polypharmacy, emotional concerns, pain, and health confidence. Additionally, taking the survey starts the patient down the path of thinking about asking for what they might need to improve their health and their health confidence. On the slide, this patient has completed the free online SAINT and receives the summary information shown here. The patient shown here has emotional issues that impact health, low confidence, and a belief that pills may be causing illness. Basic information is tailored to this patient's responses, including links to suitable tools that could be helpful. This patient was not very health confident and had a What Matters Index sum of 3, an increased risk for future costly care. Shown in blue is the patient's verbatim suggestion about what they think might increase health confidence. To reiterate, having this information available during the visit saves time, preloads the patient to think about his or her health and the importance of health confidence, and gives guidance about future steps to both of us. Because we are sharing the patient-generated information at the point of care, the patient and I start the visit on the same page, the patient's page, and the SAINT guides strategic and meaningful engagement about what matters to the patient. Real-time sharing of information from patients to clinicians has been shown to be helpful in controlled trials. This information is collected efficiently by the saint and rolled into a practice summary report, which enables me to examine aspects of my practice that might benefit from additional scrutiny and improvement. As an example, we can look at my practice's performance compared to national data. In this slide, we are looking specifically at the percentage of very health-confident patients among those who have an elevated What Matters Index, like the patient we just discussed. Although my practice's health confidence level is good compared to national data, there is still plenty of room for improvement. Hopefully, over time, with attention to this metric, I will continue to see an increase in the practice-wide confidence level. On the next slide, the left panel shows how I and 3 other practices that were using this saint have documented improvement in the health confidence of our patient population. The dots represent multiple patients in each practice. The article describes our methods. The right panel demonstrates the change in health confidence for at-risk patients in another practice when this metric is measured and then attended to. The dots represent individual patients. Though this is not a controlled trial, the movement of the practice level or the individual patient confidence levels provide evidence that we can help patients improve their health confidence. Lastly, we are beginning to monitor care for all our patients to see how much over time we can drive up health confidence and drive down the What Matters Index. This slide shows that I and another colleague seem to be moving in the right direction. In summary, we believe that DPCs will benefit by adopting the What Matters Index and the saint that supports it because actionable information is generated quickly and automatically and ensures that patients and clinicians are on the same page. The method is free and simple to use on ubiquitous desktops, laptops, tablets, and cell phones. The method is customizable by the practice. It guides services for what matters to patients. It immediately informs clinicians and patients about the risk for future costly care and directly supports DPC and employer objectives for quality assurance, accountability, and improvement. We were invited to present this information about the What Matters Index and saints because these approaches establish a foundation on which to build quality 21st century care. Next steps we'd recommend are that a small group of DPCs familiarize themselves with howsyourhealth.org for a small number of patients and discuss their methods and results. These initial early adopters can spread use and best practices among other DPC practices. DPCs have correctly minimized the numerous, insufficient, harmful measures described by the National Academy. However, third-party payers, such as large employer groups, may in the future link payment with a quality assurance method that meets our patients, our own, and society's needs. Some people might pray to a saint for help. Our recommendation is that you work with one.